So let's talk about spinal injuries and neurogenic shock. I know that y'all missed shock so much, and I bet you're so grateful that now you get to go back and learn more about hemodynamics and shock. Yay! The fun never ends in nursing school. So let's talk first about spinal injury before we get into that fun. So when we're talking about spinal injury, it's very important to know the location. Pretty much the higher up your spinal injury, the more severe or the more possible consequences that you can have from that injury. So think for cervical, which is your top, like this is the top part of your spine here, your cervical spine. See if you can breathe. And that I say see if you can breathe because if you have an injury to the cervical spine, usually it's going to affect your ability to breathe. You're not going to be able to move any of your limbs. It affects your diaphragm. It can affect your ability to even, have basic breathing movements and be able to support your own oxygenation and ventilation. When you get down to the T spine or the thoracic spine, think trouble in the torso and the toilet. So there's problems usually have injury like paraplegia, where you have injury from like your chest down. You have no motor sensation, so you can move your arms, but you can't move your legs. And then usually there's a lot of trouble with bowel and bladder functioning and things like that. And then when you get in your the lower part of your spine, which is known as your lumbar spine, think lower extremity issues and possible loss of bowel and bladder. Say it 5 times fast. And so, in other words, like up here at the top, the cervical, respiratory issues, can't move any extremities, very dependent on machines and other things to help support me. Thoracic spine, I can move my arms, but I'm going to have trouble with my bowel and bladder functioning, and I cannot move my legs. And lumbar spine, a lot of times they have things like they can have some paraplegia still, like where they can move their arms but not their legs. Sometimes they just have decreased sensation or loss of some function in their motor extremities in their lower. And then sometimes they also still have those bowel bladder issues. So pretty much just think of how it goes down in the body, and you can kind of see in this picture, it starts kind of the whole body. Then as you're moving down, kind of how much function you have. And everyone's spinal injury is a little different. So why do we need our spine anyway? Well, our spine, as much as it may seem like our brain is the powerhouse, keep in mind our spine is the highway. So that if we just had a brain up here and that's all we had, it would be it would have no purpose because it has to have a highway to send those beautiful signals it's creating to the rest of our body. So we need it to breathe, we need it to regulate our blood pressure, our bowel bladder function, movement, and our temperature regulation. So when we have a spinal injury, these are a lot of the big things that start to have issues. So symptoms of a spinal cord injury, I mean, they can go head to toe, like we talked about. For respiratory wise, if I have a cervical injury or a high up injury in my neck, in my spine, what happens is I can end up hypoventilating. Literally, the nerves that are up in the that send signals up through my cervical spine, when that's broken, because kind of look at this picture, it's almost like a wire comes unplugged. So kind of think of like how like you're trying to plug in your computer or something, and then it's not charging, and you're like, why isn't my charger working? And then you look and there's like some wires sticking out, like it looks like you've bent it so many times. So that's what can happen sometimes with your spine with a spinal cord injury. And so it's not going to get the same signal, so it can't charge. And just like the same thing, it can't send signals to the rest of your body when you have a spinal cord injury. So for the respiratory problems, it's not sending a message to your diaphragm to tell it to breathe. And if it is, it's not effective enough where you can actually get good ventilation. You can also have difficulty clearing secretions that are at a higher risk for aspiration. Cardiovascular wise, they can have the spinal shock and the neurogenic shock, which they can have things like vasodilation, bradycardia, and changes to the vital signs. Urinary wise, they can have what's called a neurogenic bladder, where they can retain urine because there's nothing sending a signal to tell them, hey, let go of that urine. They can also have incontinence as well. Gastrointestinal, they can have dysphagia. Their muscles of their throat and their mouth, and throat and sorry, not necessarily mouth, but throat, neck, chest, and stuff like that. All the stuff that you're using to help you swallow, those can be decreased and weak, and so we can't swallow properly. You can have a paralytic ileus, or in other words, like your your spine isn't sending signals to your stomach to tell it to squeeze, like that peristalsis, that squeeze that we have that gets things moving. You can also have a neurogenic bowel where you can get constipation, other things where like your bowel's just not getting the signal that says, hey, it's time to let that crap out. Like, there's nothing sending it that signal. Other things, the patient's at risk for skin breakdown. They may be unable to regulate their temperature and they could have a very high or usually more often a very low temperature. They can have muscle atrophy. In other words, their muscles can start breaking down. They're going to be at risk for nutritional deficiencies, and they can also have complications of immobility like blood clots and neuropathic pains. That can be like numbness, tingling to like burning pain, like almost feels like they're on fire. So in an emergency situation when a patient has a spinal injury, some of my actions are going to start with stabilization. So this is like any other fracture. The best thing that I can do is get it in normal alignment. So we talked about like in head trauma, how you want to keep it very stable and you want to always assume an injury. And so same like if a patient comes in and I think that they have a spinal injury, I'm going to put them in protective precautions and put them in a seat collar. I'm not going to allow them to turn their head. I'm going to support their neck so that we prevent any injury. Some of these patients may have cervical traction, like I said, C-spine precautions, a collar, and they may need a surgical interventions to fuse that to prevent them from having an injury there. I want to protect their airway because, again, if they have a cervical injury, especially that high up injury, I'm going to, they may not be able to have a diaphragm that's working effectively enough to support their own respiration. So they may need to be intubated. So I need to watch their oxygenation and their ventilation. Breathing, I'm going to support by keeping their, their head of bed elevated if possible. Now, keep in mind when a patient has a cervical spine injury, we usually have them flat, just like this person in this picture. And so the reason why we do that is because if they're sitting up, their neck gets flexed. So we really want them to be kind of in a flat, neutral position. So what we do is instead of putting their head of bed up, instead of like kind of sitting their head of bed up like this, what we do is we actually just put their whole bed up. So it's like they're actually like tilted. Like, we talk about Trendelenburg, Trendelenburg or reverse Trendelenburg. So we kind of put them in the position where their head is going to be up here at the top of their bed and their legs like this. So it's not actually flexing them forward, but their head of bed is still up to prevent aspiration. And then we also do things like high flow oxygen, support oxygenation to make sure they're getting good perfusion to their brain. We're also going to monitor for shock, like we're going to talk about the neurogenic shock later, and maintain their hemodynamics. A lot of these patients, because of their spinal injury, can end up having bradycardia and hypotension, so they may need medications like atropine or vasopressors to support them. So one of the most common, and when I say common, it's not that it happens to every patient, but one of the most deadly things, and one of the things that I probably have seen the most like NCLEX-like questions about is what's called autonomic dysreflexia. And this is something that happens with spinal injuries. Excuse me. It only happens with certain levels of spinal injuries, and like this mnemonic says T6, but double check your book and make sure that that matches. But it's a certain injury, because I feel like your book might say something different like T8 or something, or T7. But keep in mind that effectively it has to be at a certain level injury. And a certain level injury or higher. Like this wouldn't happen to someone who had a lumbar spinal cord injury. So it has to be a T6 or or higher injury. So only people with higher level injuries get this, in other words. And autonomic dysreflexia is a problem with a reflex. So pretty much what happens, and a lot of people find this confusing, so I'm going to do my best to explain it. What happens is kind of think of it like some sort of stimulation happens below the area of injury. So let's say that some of the most common things that happen is that like their bladder's full. And again, remember we talked about how they're not getting that stimulus to empty their bladder, so their bladder's full. And so their body's responding and saying, hey, guy, my bladder's full. But it can't respond the way that it used to. So what happens is that, below the level of injury, a massive vasoconstriction occurs. So some stimulation happens and the body's like, oh, I don't like this. I want to get rid of it. So it's trying to compensate for it. So it vasoconstricts below the injury. And then above the injury, what happens is that they like, like up here in their body. Their body's like, whoa, there's some pressure going on down there. I need to respond to that. And so it starts vasodilating. So pretty much you have vasodilation up here. Their face is going to be flush. They're going to be diaphoretic. We call it, and they're going to have bradycardia because their body's trying to respond to all that pressure from down there by like lowering the heart rate to try to help to decrease some of that pressure. But here's the thing, like pretty much like above where the injury is, diaphoretic, vasodilated, bradycardia. Below the level of the injury, there's like all of this massive pressure. But remember, there's something that chopped this cord here, excuse me, in the middle of the spine. So even though the top of the body's doing something and the bottom of the body's doing something, and they want to talk, they hear what each other's doing, they can't talk to each other. So in other words, even though the top of the body's like, "Hey, buddy, I see there's all this pressure here. Let me slow you down." It because the spinal cord is there's a tear in it. It can't send that signal to the bottom of the body. And so in other words, there's all this pressure down here, and then there's the body up here trying to fight it, but it can't send that signal to the bottom. So pretty much you have bradycardia, hypertension, you have headache, diaphoresis, flushed, really, really uncomfortable. And so, emergency management is this is one, they're incredibly hypertensive. And so what I need to do is sit them up. And so keep in mind, I know we just talked about an emergency management that, hey, you don't want to flex them or set them up. That's when they're like immediate, like when before they've had surgery. Autonomic dysreflexia, I should mention, is something that happens later on. It's not something that usually happens early, like right after they've had their spinal injury. It's something that usually starts happening later when they're in like, when I used to do spinal rehab, we would have this all the time happen in rehab. Excuse me. And so pretty much what happens is that we sit them up to try to decrease their blood pressure because when you sit a patient up, it actually decreases their blood pressure. And the biggest thing is I need to treat the cause because I can sit here all day. I can treat their blood pressure. I can give them atropine for their heart rate being low. And let me take a drink of water real quick. But at the end of the day, the only thing that's going to help them is remember the body is responding to some sort of pressure from down here, whether it's my bladder's full, I need to poop, have tight clothing on, something like that is restricting or causing that vasoconstriction that the body's responding to. So I need to remove the stimulus. In other words, remove the cause. And so that's going to be my first intervention. Is what I want to go is I want to go and do something to try to relieve that. Now, if I relieve the cause, I empty their bowel, empty their bladder. So maybe I straight cath them. Maybe I do, I stimulate them to have a bowel movement. I've sat them up, and I've removed all the stimulus that could be hurting them, and their blood pressure is still high. I might give them some antihypertensives after that, but we're not going to just treat the symptoms. We need to treat the cause because otherwise we're really not going to get to the bottom of it. So hopefully that makes sense. I know that this is kind of confusing, but there's lots of good videos around about it. So feel free to watch some if this one doesn't make sense. There's other devices and treatments that can be used as well. There's cervical collar, and what we do is we recommend people. The nurses are recommended to change the pads on a daily, or even like at JPS, we change them every shift. We change those collar pads because we don't want them to get any sort of infection. But effectively, because it's real sweaty and yucky around your neck. But you have your cervical collar, and that's going to just maintain so that you can't be sitting over here doing this and moving your head in all directions. We have what's called a TLSO brace, and this is a brace that goes around the chest and the body, stabilizes the thoracic spine. And so for this, of course, I want to make sure that the brace is positioned correctly. It literally encircles the chest and the abdomen. And so we want it tight enough where it's providing stability, but not so tight that the patient can't breathe or can't ventilate. So it's really finding that balance, making sure that's on correctly, but then also watching their breathing, watching their skin, and making sure that we're not putting too much pressure on them. If they're in cervical traction, we're going to do pin care and make sure that we're preventing infection there. There's what's called a halo, and that's where there's actual, it's what do you call them, pins that are inserted. It's like pretty much think of like having an external fixator like you can have on your foot, but on your head. So it's like keeping your spine in place, to prevent you from having an injury. So it's kind of like having a C-collar on a more long-term basis, or kind of like, it's not traction, but it's pretty much like a stabilizer for the spine, but it's a huge metal device that looks like, it's called a halo because it goes around your head in a circle. And then there's pins actually inserted into your skull to help keep everything in place. And this is something that it wraps around the chest, the part of the brace wraps around the chest. And so I have to have wrenches at the bedside. So if for some reason I have to do CPR, I can remove that device right away. I need to monitor the skin and inspect again those pins to make sure there's no infection. And there's also this device, which is what's called a roto rest. And this is great. Like, remember how I said that we really want to keep that spine stabilized? Like, I don't want them flexing, bending up when they're acutely having a spinal injury. So this bed is great when they're in that acute period. Maybe we're waiting for them to go to surgery, or maybe they're not a candidate for surgery. So we're trying to let that spinal injury heal. But we also want to turn them and make sure that they're getting, good, they're not getting pulmonary complications or other complications. So this bed literally tilts them side to side while keeping their spine straight. So that way they're turning and not getting pressure injuries, and getting some, movement without moving them in a way that's going to worsen their spinal injury. So here's some pictures. Here's the Halo device, like we talked about. You can see how, it has, like, this is something that they're always going to have on all the time, because it's literally screwed into their head. And so there's some things here on the front, usually some bolts, and then there's like a wrench that you keep at the bedside just to kind of make sure that you can easily take that off if we had to do CPR. Here's a C collar and then a TLSO brace to kind of get a visual in there for what those look like to help support the spine. So general treatments for respiratory, we're going to support their airway oxygen breathing. A lot of them, they're not going to be able to cough, deep breathe and cough on their own. So like this woman, you can see what she's doing. She's doing what's called what do you call it? Like there's a huff cough, and then there's also an assisted cough. And what she's doing is like an assisted cough, which is really like you're being their muscles and pushing up because they cannot cough, or they don't have the strength in their muscles because of their injury to be able to do that same cough and stuff up. So they really need aggressive respiratory therapies, especially to get their secretions up. I'm going to manage their blood pressure, and they can also have really bad orthostatic hypotension, because like you and me, when we stand up, like we have all our brains like sending signals to tell us, hey, she's changing positions, catch up. But with a spinal injury, they're not going to have that. And so we need to really change their position slowly. If they move up quick, I can't tell you how many times I've had a patient pass out because I was getting them up out of bed and they're laying down, and I start to sit them on the side of the bed, and then there they go, passing out. And so, and I'm not laughing at the fact that they passed out. It's a body's reflex. It can't help it. But you just have to take it really slow with these patients. And then for fluid wise, we want to make sure that they're getting their feeding. A lot of them are going to have like permanent feeding tubes. They may need parenteral feeding for a while, like through an IV like TPN. And then when they learn to feed themselves, they may need adaptive equipment to help support their nutrition. Bowel and bladder training, and I'm going to talk about that in separate slides, but usually with their bladder, they're going to self-catheterize like 4 to 6 times a day, and then they're going to have a daily bowel program to get their bowels on a routine. I'm going to give them prophylaxis to prevent blood clots, to prevent stress ulcers, and manage their pain. And they also have a lot of spasms in their muscles, and so especially since they're not being used, and so giving antispasmodics can help. So let's talk about a neurogenic bladder. So a neurogenic bladder, again, is one where they're holding onto or retaining urine. And so what we do is we do bladder training. We can do things like time voiding, like put them on the potty every so many hours, and sometimes they can empty. We can put them on a fluid schedule to make sure that we're spreading out their fluid where their bladder's not getting overwhelmed with too much fluid at once. But a lot of these patients end up with, acutely with an indwelling catheter, and then they might later get a suprapubic, like a permanent catheter that has the opening on the outside front of the body. And then giving them medications like anticholinergics can help relax that muscle to allow them to urinate. Tricyclic antidepressants and alpha blockers can also help with that smooth muscle relaxation. Alternatively, there's also surgical options like, we call urostomies, or they can have sphincter surgery to help with that. A lot of these patients end up doing what's called straight catheterization, which is where like every 4 to 6 hours, like we talked about, they're going to stick a catheter up, drain their bladder, and then empty that. And so they're just kind of doing it on a schedule versus like knowing, hey, I need to go and go into the potty. And so then they're going to need to, don't mind that I'm calling it potty. If you can't tell, I recently potty trained my son. So yes, I'm definitely still in, need to go to the potty mode. So anyway, bathroom, I can talk like an adult. And so at the end of the day, these patients, they kind of get trained to get on a regular schedule. And because remember, we talked about with that autonomic dysreflexia, if their bladder gets full, it's one of the big triggers. So it's really like keeping ahead of this and watching their fluid levels and making sure they're not taking in too much to overwhelm themselves. And then of course at home, like, they're not doing it sterilely. So we're doing it a clean technique. So it's definitely just learning about how that works. So there's also bowel training. We want them to have a diet that supports good bowel health, like enough fiber. We need them to get enough fluid, like 2 to 3 liters of fluid. And again, like I was mentioning on the last slide, we're going to spread it out throughout the day. We don't want them drinking a liter at one time, filling up their bladder, and to the point where they could get that autonomic dysreflexia. So we want to spread it out. We usually establish for bowels a regular schedule. So like when I used to do spinal rehab, it was like every night at this time, like what I would do is I would transfer all the patients that I had to the toilet and get them on their bowel program. Now, some of them, I just sat them on the toilet and their bowels were trained. Like they know it's, hey, it's 7 o'clock. It's time to go. And they would automatically go. A lot of them, what I had to do was insert a suppository in them or do what's called digital stimulation, which you're going to love this. You literally stick your finger up and just move it around to stimulate the bowels and say, hey, it's time to go. So yeah, that's what these patients do. And after a while, it gets on a schedule. And like I said, some people eventually it's just like, hey, it's time to go. Some of them are always going to need or depend upon like a suppository or something else to remind them, hey, it's time to go. But again, kind of keeping this regular schedule. Um, Upright position, regular activity, suppositories, and that manual stimulation is going to be all different, all those parts of the bowel program. And patients can learn to do a lot of this stuff by themselves at home, depending on their level of injury. So overall nursing management, it's going to depend on the level of the injury, but I want to, of course, maintain adequate position to prevent further injury. So spine precautions, which is making sure that their neck is staying neutral. Log roll, which means when I'm turning them, I'm turning their whole body. I'm not twisting their body over. I'm turning their whole body ergonomically where they're not going to be twisting or turning in a way that's going to worsen their spinal cord injury. I'm going to monitor their skin closely, watch out for skin breakdown, support their bowel and bladder. The hydration and nutrition is going to be so key, finding that balance to get enough, but not too much and overwhelm the bladder. DVT prophylaxis, teaching about, how to give them the most independence and functioning as possible, and a lot of emotional support. So it's really head to toe, because remember, the spinal cord affects things on every level. So now let's get into the scary stuff, the shock. And so there's two types of shock, and people usually really struggle with these. So let me kind of break it down. There's what's called spinal shock, and then there's neurogenic shock. When we talk about spinal shock, we're talking about like more of a reflex, like musculoskeletal issue. There's with spinal shock, this is saying because I had a spinal injury, I go into the state of shock where my reflexes are down, I've lost sensation, and I have a flaccid paralysis. This happens right after a spinal injury. And it doesn't mean like, so, like sometimes people, they'll have a rough spinal injury and we'll be like, oh my God, they're paralyzed, but we don't actually know yet. A lot of times they're in spinal shock, which means in that short period after their injuries, like their body's like, oh my God, some trauma happened. So it kind of shuts down. It stops sending signals. It's not, doesn't mean that the cord is severed. But sometimes it's kind of seeing what happens with that cord injury, because a lot of times they're in spinal shock. So this is like the physical musculoskeletal kind of issues that are happening. Well, then there's neurogenic shock, and this is a sympathetic nervous system or a blood vessel problem. And we talked about vasodilation that can happen with shock, like with sepsis and stuff like that. But this type of neurogenic shock is a little different. This is the only type of shock that you're going to have bradycardia. And we talked about with sepsis, you can have some hypothermia, but this one's going to be much more pronounced. So like the big thing is, of course, with any type of shock, your cardiac output's low, your blood pressure is going to be low, your MAP's low, all that stuff. But with this one, you have a low heart rate. It's the only type of shock where you have a low heart rate, because all the other ones, remember, it's cardiovascular and your heart is compensating. But remember, in this type of shock, you have a brain problem, and your brain that regulates those wonderful things in your body, it cannot send that signal. Excuse me for all my coughs tonight. It cannot send that signal to tell you to speed up, like to respond and stuff like that. This is a sympathetic nervous system issue where your body's not functioning and responding the way that it's supposed to. So in other words, usually like when your blood pressure goes down, your heart rate goes up. But with neurogenic shock, this is the only one where your blood pressure goes down, heart rate goes down. It's all because your brain's not having that same functioning to tell your body, hey, this is where you compensate. They also have decreased temperature because your thermoregulation is off, because that is one of the functions of your spinal cord. So how do I manage neurogenic shock? Remember, this is a distributive shock. So with these patients, they're not actually like, it's a huge vasodilation. So again, it's like fluids going into the wrong places. So the best things that I can do to help this patient, I want to stabilize their spine. They're going to have a low cardiac output, low systemic vascular resistance. Because remember, SVR, that's the resistance. And if you're vasodilated, your SVR is going to be low. They're going to have a low MAP and blood pressure and have bradycardia. And the two things that I talked about, my main treatments are going to be to treat the heart rate. So I'm going to give atropine, dopamine, things like that to treat that heart rate. And then I'm going to treat the hypotension with vasopressors. Because remember, I'm vasodilated, so I need some more squeeze to my blood vessels to help to counteract that shock effect. So that is spinal injury and spinal shock in a nutshell. Hopefully this got you open up to the world of spinal injuries. You probably didn't realize it was so complicated, but definitely there's a lot here, but hopefully this helped to start break it down and get you excited about what's next. See you next time.